Well, I'm super excited to be here. I see a lot of familiar faces. We've all been working in this area for a really long time, and we still have a lot of work to do. So today I'm going to talk about just very briefly some big topics. There's a lot to know. Definitely feel free to look at the guideline recommendations for care if you're interested in those, if that's something that is part of your work or your life. Remember, all of the Department of Health and Human Services guidelines are available online, and it's a super easy website. It's aidsinfo.nih.gov, and that'll get you to all of the current guidelines. So today I want to talk about the recent updates to the DHHS Adult and Adolescent ARV guidelines, describe the recent updates to the perinatal guidelines, and also talk about some prevention strategies that we all can consider in our work, talking to our patients, talking to family and friends that might be at risk. So I think it's important to think about this not only for our jobs, but for our lives as a whole, because Florida has a lot of risk in it with exposures, and it may not just be in our job that we need to be talking about this. It's a lot to cover in a short time, so it's going to be a whirlwind. I'm from Tennessee, but I can still talk fast. So we're going to start with the adult and adolescent guideline updates, and I'm going to start off with a case. And I want you guys to think about these patients as if they're your friends or a patient that you're taking care of, and tell me what you think. So PR is a 23-year-old man diagnosed with HIV 3 weeks ago. He's coming in, he got his labs done, he did his eligibility, he's ready. His CD4 count was 625, his viral load was 15,000, so that's pretty darn good. All other labs were within normal range. He's got normal renal function. He feels well. He's not currently sexually active. Once he got that diagnosis, he decided he was going to take a break and think about life and get well himself. So what do you think? Should antiretrovirals be started today for him? Should we talk to him about that and recommend that? Yes. Even though his CD4 count's super good, his viral load really isn't that high, yeah, we need to be talking about treatment. And this is something that the new guidelines that came out in April updated. We've always known in our minds that folks with HIV infection should be treated, but the question was when to start that treatment. And the strength of those recommendations and the guidelines has changed over time. It used to be CD4 based. So in the earlier version, if a CD4 count was less than 350, starting antiretrovirals was a strong recommendation with strong evidence in A1. 350 to 500, it was less strong in A2. Less than 500, it was that was supposed to be greater than 500. It was a B3 recommendation. So at that time, it was like, okay, if your CD4 counts, over 500, maybe you can wait. But that's not what we think now. In July, the guideline updates took into account 2 new studies that suggested that anybody with HIV infection, regardless of their CD4 count, should be considering antiretroviral therapy. We should be recommending that strongly. There may be situations where it's not appropriate to do that. That would be on a case-by-case basis, somebody that really doesn't want to take meds, isn't interested in taking medications. That might be a situation where you're not going to win the compliance battle, and you may have to wait, and that would be a discussion with the patient. You'd explain the risks of doing that, and you can talk about these next 2 studies that I'm going to describe very briefly for you. So the START trial, I don't know if you guys have heard of this trial, but this is one of the ones that said, hey, everybody should be treated regardless of the CD4 count, because we know the risks, even in people with good CD4 counts, of having complications are pretty high. So this START trial was a strategic timing of antiretroviral therapy, and the goal was to determine the risks and benefits of immediate initiation of antiretroviral therapy in asymptomatic HIV-positive people with CD4 counts greater than 500 versus deferring until the CD4 counts were lower. This study was like the most well-balanced study I've seen. This randomization chart, I know you guys can't see it in the back, but there's very little difference between the groups. I was really impressed with how well they were able to get this randomized so successfully. And they do have quite a number of ladies in this study. A lot of our studies don't have so many ladies. This one has a number of ladies. And if you look at this, Even I can tell that this blue line for deferred, let's see if I can get this, oh, there we go. The blue line is the folks that deferred initiation till later. They really didn't do so well. On the left-hand side, that's a percentage of patients that had the primary endpoint of serious AIDS or non-AIDS events, and that can include cardiovascular events or other events that suggest complications of HIV and non-AIDS events as well. So those folks that had the deferred initiation didn't do as well, and it was statistically significant. And the study actually got stopped early because they saw that people that were in the deferred side really didn't do well. They stopped the randomization. Everyone was offered therapy at that point. The other study that helps us know that it doesn't matter what your CD4 count is, you really should be on therapy is the Temprano study. It was a randomized controlled trial conducted in Côte d'Ivoire. It enrolled 2,056 HIV-infected patients with CD4 counts less than 800. They were randomized into 4 groups. And remember, in some parts of the world, TB is a big, big problem. And TB and HIV together is a humongous problem. And this happens to be one of those areas. So they were looking at not only starting HIV therapy, but starting treatment for latent tuberculosis in people that were HIV positive. So they had folks that were given immediate antiretroviral therapy, those that were given immediate antiretrovirals and isoniazid prevention therapy, those that deferred just the antiretroviral therapy, and those that deferred both the antiretroviral therapy and the isoniazid prevention. And if you look, again, there's a blue line. The deferred antiretroviral therapy had a much higher probability of death or severe HIV-related illness than folks that went on both antiretroviral therapy and the isoniazid prevention therapy. And that helped the guideline committee make their new recommendation a strong recommendation, an A1 recommendation, that everybody that tests HIV positive, regardless of their CD4 count, should be offered antiretroviral therapy. So here's another case. The same guy, he's there. You told him about these 2 great studies. You maybe even pulled him up on the computer and showed him, hey, look at this blue line. This says you need therapy, or you could have higher risk of complications. So he says, okay, I believe you. I'm going to start therapy, but I really don't want to take a bunch of pills. I really need to have a very simple regimen, one that I'm going to tolerate, one that's not going to interfere with my life because I don't want to quit my job. So you look, his resistance test says, hey, you have no significant mutations. Anything should work for you as far as we can tell. Your kidneys are good. Your liver's good. Your bloodstream is, your blood numbers are normal, so you can take anything. He's HLA B5701 negative. Who knows what that test is for? Yes, it's for abacavir hypersensitivity. It's a genetic marker for the risk for allergic or hypersensitivity reaction to abacavir. We need to get that in anybody that we're considering treatment for abacavir. We didn't do this all the time for everybody because we didn't use abacavir so much, but now we've got this awesome single tablet regimen that has abacavir in it, and so if we're going to consider all possible single tablet regimens, we need to know that test. So everybody think about what is in the preferred guidelines, if you know them, and tell me what you might pick for this patient or reasons for why you might pick one over the other. So these are all single tablet regimens. There's elvitegravir, cobicistat, tenofovir, and emtricitabine in one tablet. Who knows what that is? Stribild, right? There's efavirenz, tenofovir, and emtricitabine. Everybody knows that one. Atripla. Dolutegravir, abacavir, lamivudine. Triumec. Wow, you guys really know Triumec. Rilpivirine, tenofovir, and emtricitabine. Complera. Okay, so all of these drugs work. They all have little quirks about them that we need to think about. So does anybody know whether Stribild is preferred in the DHHS guidelines? Is that a preferred antiretroviral regimen for an antiretroviral naive patient? There's 50-50. The answer is yes, it is. And the Stribild's a great drug. people do well on it. They like it because it's a single tablet. It does have some renal toxicity risks, and so people need to have an estimated glomerular filtration rate over 70 to start it. And this guy does, so he could certainly go on that. It needs to be taken with some food, doesn't have to be a full meal. The next one is our friend Atripla that we have used for years. Is that on the preferred, is it preferred in the guidelines today? No. Does anybody know why? Okay, so it has neuropsychiatric effects, and some people do become very depressed or suicidal on that medication. It can cause dizziness, it can cause vivid dreams, nightmares, and a lot of patients, those vivid dreams, nightmares, and stuff get better after 2 weeks, but for some patients it really doesn't, and so that's why it's moved down to an alternative regimen. If somebody's on Atripla, do they have to come off if they're doing awesome on it? No way. They can stay on that. If they like it and they're not having any problems, there's no reason to change it just because the guideline says it's an alternative regimen. If they're doing good, that's fine. And you can actually start people on it. Just because something's in the alternative regimen doesn't mean you can't use it. Just means you have to think about it. It may not be for everybody. All right. What about dolutegravir, abacavir, lamivudine, Triumec? Preferred? Not preferred? Preferred. Okay. So that one is preferred. It's a large tablet. It may not be for everybody that has, pill issues with swallowing, but it is a preferred drug. It doesn't have to be taken with food. It can be taken with or without. Then the last one is rilpivirine, tenofovir, imtricitabine, or Complera. Is that preferred or alternative? It's alternative. It's not indicated in people that have a CD4 count less than 200. Or an HIV viral load over 100,000, and it does have to be taken with a meal. The recommendations are a 400-calorie meal, so it's not for everybody. Could be for this guy, though. It has very, very few side effects. If he's going to be compliant and be able to take it with a meal, there's no reason it shouldn't work for him. So recommended options, we talked about these. You've got the dolutegravir, abacavir, 3TC, only for people that are HLA B5701 negative. Dolutegravir plus tenofovir imtricitabine also is recommended. Elvitegravir, cobicistat, tenofovir imtricitabine, which is Stribild, only for people with a pre-treatment creatinine clearance greater than 70 milliliters per minute. Raltegravir plus tenofovir imtricitabine. I didn't bring that up in the last slide because it's not a single tablet regimen, and it does have to be dosed twice a day, and that's not what this patient was looking for. But it's great. It has few drug interactions, but it is a twice-a-day regimen. Protease inhibitor-based regimen, darunavir boosted with ritonavir plus tenofovir and tricitabine is also preferred. What do we not see on there anymore? Was on there before. We use it all the time. Atazanavir is now moved down into the alternative. So that was in the preferred before. It's down in the alternative. So this is what DHHS currently has for preferred antiretrovirals. Doesn't mean you can't use other things, but these are the ones that they think most people are going to do well on. And it's a good option for antiretroviral naive patients. These are the alternatives. Sorry, it's yellow. I stole it right out of the guidelines, and I couldn't make it not yellow. So there's where efavirenz, tenofovir, imtricitabine went, which is Atripla. There's Complera, only for people with a pretreatment HIV RNA less than 100,000 and a CD4 cell count greater than 200. The PI-based regimens, there's your cobicistat-containing regimens. Those are there. And those are only available combined with 2 protease inhibitors, currently atazanavir and darunavir. Perinatal guideline update. I love these guidelines when they get updated because it makes you think. So we're going to talk about a couple. MK is a 30-year-old woman. I just screwed these slides all up. No, I didn't. Okay, MK is a 30-year-old woman with HIV infection who recently got married to an HIV-negative man. They are not ready to have a baby. She's on Depo, but they don't always use condoms. She's heard some people talking on the street that maybe using Depo increases the risk of HIV transmission. Some people really worry about this. So she comes to you and she says, Doc or nurse or PA or whoever you are, you're my caretaker, tell me whether I am going to have an increased risk of giving my husband HIV if we're using Depo. What do you say? Because people worry about this. There's been some discussions. Well, what are you going to tell her?
One of the things you can tell her is PrEP.
Okay, so Martha, thank you, Martha, said one of the things you can tell her is about PrEP, and we'll have that conversation too. But in terms of the increased risk with hormonal birth control, there was a large guidance statement that came out of the World Health Organization looking at the possibility that hormonal birth control could, can it cause increased risk of transmission? Because some people have worried about that. They looked at a lot of studies, and their consensus was HIV infection does not preclude the use of any contraceptive method. That was an A2 recommendation. We're still going to recommend condoms. We're still going to talk about PrEP because we want her husband to be safe because they don't always use condoms. So we got to think about, all the different ways that we can help our patients. But if somebody comes in worried about birth control pills or worried about Depo, you can tell them, hey, there was a big study, and the World Health Organization said, we looked at a bunch of different studies. We don't feel like there's a risk. Now, you do have to take into account drug-drug interactions in terms of pregnancy prevention. There are lots of drug interactions with the protease inhibitors, with cobicistat. We have to think about these things. If you take those into account, you avoid things that may have interactions and problems, then the chances of preventing an unwanted pregnancy are much higher. So remember, if you're wondering what people can take, Table 3 in the new perinatal guidelines does go into that. And remember, condoms should be used. All right. A 23-year-old woman diagnosed with HIV infection at 8 weeks gestation was seen at a high-risk OB clinic, not UF. She had normal renal, hepatic, and hematologic function. Her CD4 count's great, 550. Her viral load is not super high. It's 25,000. She got started on AZT and 3TC Combivir, 1 tablet daily, and then lopinavir ritonavir, which is Kaletra, 2 tablets once daily. Thank you, Vicki. Can you spot the error in dosing? And Vicki spotted it. Can anybody besides Vicki, who does this every day, tell what the problem is here? These are old drugs. I figure some of you guys might know what this, even the standard dosing for non-pregnant people would be. Okay, Karen. Yeah, Combivir has to be dosed twice a day. Kaletra is 4 tablets once a day for non-pregnant people, but you can't dose it once a day for pregnant women. It has to be 2 tablets twice a day, and then there's expert recommendation in the guidelines that maybe in the 2nd and 3rd trimester, it should go up to 3 tablets twice a day. If you're not going to bump it up, they do recommend consideration for pharmacologic testing of drug levels. So definitely this is not only not the right dose, it's also not preferred anymore. So Combivir and Kaletra has been moved to the alternative regimen. You can still use it. It works, but it does have more side effects. The patients tend to have more nausea with it. It's a complicated regimen, right? Because once you get into your 3rd trimester, you're taking 3 pills twice a day, so 6 total pills a day. Most people really don't love that when there's easier options. So here we are today, and I think this is a kind of exciting place to be because finally we have some more easily tolerated medications that we can use in pregnancy for our ladies. So still you're going to have that 2-in-RTI backbone, but you can use a non-nuc or protease inhibitor boosted with ritonavir or an integrase inhibitor. This is the first time we've seen an integrase inhibitor on the preferred regimen for perinatals. So if you look, you've got the 2-in-RTI backbone. Remember, with abacavir and lamivudine or Epsicom, you have to be HLA-B5701 negative before you can get it. You can also take tenofovir and tricidabine or Truvada, or you can do them separately, tenofovir and 3TC. Or you can do Combivir, zidovudine and 3TC, but remember that has to be dosed twice daily. The PIs, atazanavir, ritonavir is still preferred in the perinatal guidelines. Darunavir, ritonavir is preferred. That has to be dosed twice daily. And then for the in-RTIs, we talked about this at the last Keeping with the Pace that efavirenz is now on the preferred options in the guidelines for perinatally infected women. We always used to stress about this because we know that it's teratogenic. But after the first 8 weeks of pregnancy, that risk is gone, so you can start it. If somebody's already on it and they get pregnant while they're on it, then they can stay on it, because by the time they recognize that they're pregnant, the cat's out of the bag. It's too late really to do anything different. You don't have to change it. Then you've got your integrase inhibitor regimen, which is raltegravir or Icentris. Remember, that does have to be dosed twice daily. It's very well tolerated, and it has few drug interactions. So those are our current preferred regimens in pregnancy for antiretroviral naive patients. Remember, there may be patients that have been experienced on drugs for a long time and may not have the option to take these because of prior resistance. So folks that are already on a regimen that's working for them, it's not their first regimen, they probably should stay on their regimen. This is really for antiretroviral naive patients that you would really stick to this. Alternatives, there's your Kaletra. Remember, though, it has to be dosed twice a day in pregnancy, starting off 2 tablets twice a day in the first trimester, and then the recommendation is to go up to 3 twice a day. So that's a lot of pills. You can use Complera, it's an alternative, or rilpivirine plus a preferred 2 NRTI backbone. So that's another option, not first line, but it may be appropriate for some ladies. So Bob and Ann come for preconception counseling. Bob has had well-controlled HIV for 5 years. Ann is healthy, and she doesn't have HIV. They've discussed adoption, using a sperm donor, but they want to have a baby that combines the 2 of them. What are their options? There's a lot of options. Donor sperm from an HIV uninfected man is the safest option, but that's not what they want. They want to have a baby that combines both of them. You could consider having him give a sperm sample, do a sperm prep with intrauterine insemination or IVF. That's definitely considered a safe option, but it's very expensive. Doesn't always work, but that is something that you can recommend for folks. You can consider periconception PrEP for the husband and have her do an ovulation testing kit and have the high-risk sexual behaviors for pregnancy. Any of us that have babies, we don't have anything to say about that. So she can do that, and he can be on PrEP for sure. Now, the HIV-infected partner should receive effective antiretroviral therapy with sustained suppression of plasma viral load below the limit of detection. And it is recommended, if you can possibly get it, to get a semen analysis of the HIV-infected man, because sometimes they won't have healthy sperm and they will be engaging in high-risk behaviors without a good probability of pregnancy. So I wanted to have some time to talk about HIV prevention in this talk, because in the next session that we're going to have, we're going to talk about PEP and PrEP as a panel. And I want you guys to all think about the questions you might have about PEP and PrEP as we're going through this. If you already have questions, write them down. We really want you to have an opportunity to ask questions about PEP and PrEP. Think about, how you might incorporate this into your practice, what obstacles you might have. We may not have all the answers, but we need to have a conversation, I think, as a group about what we can do for prevention. Gay presented very eloquently the problems that we're having. We know people are engaging in high-risk behaviors, often without proper protection, and we need to be the voice that says, hey, there are ways that might fit with your lifestyle that you can prevent HIV. So here's our prevention and care provider toolbox. Testing is very important. People do need to know their HIV status. I really encourage even my positive patients to make sure that they see a test result for any future partners, because they need to know, they need to have a conversation with their partner about the risks that they're truly taking. Plus, I tell them I think it's smart to know ahead of time, because if that person later is tested HIV positive, they're going to think it came from you. And so, we have this conversation about that. I hope everybody else kind of thinks about it, because it is a big burden for people to carry in their hearts. if they do think that they've transmitted HIV to somebody else, and maybe that's not really what happened. Maybe this person was already infected. We've got prevention for positives. Remember, being on antiretroviral therapy and having an undetectable HIV viral load by itself is a form of prevention. Linkage to care, when somebody gets diagnosed and they're not in care, at the very beginning of infections, when they have very high viral loads, we need to get people linked to care and in treatment as soon as possible. Provide that prevention method at every possible visit so we can help folks think about what their options are for prevention and act on them. Safer sex counseling, safer injection practices. Florida does have large numbers of people that still engage in IV drug use. That's not the primary mode of transmission in our state, but things can change all the time. Look at Indiana. You don't expect it, but we have to be prepared for it. Miami's now entering into a needle exchange program. We don't have that statewide, but it would be great if we did. So those safer injection practices, we don't have a needle exchange, but can we teach people how to clean their needles? Yeah, we can do that. We can encourage them not to share their needles. There's a lot of things that we can do talking to folks that are IV drug abusers that aren't HIV positive yet, and those that are HIV positive already. Post-exposure prophylaxis is another way to prevent HIV, keeping people retained in care. And then pre-exposure prophylaxis are very critical things to think about. So we're going to talk about post-exposure prophylaxis first, and then pre-exposure prophylaxis, and we're going to have a panel discussion about those two topics following our next break. So what is PEP? Post-exposure prophylaxis is the administration of antiretroviral medications after a high-risk exposure to the HIV virus in an attempt to avoid HIV transmission. There are two post-exposure prophylaxis scenarios, occupational versus non-occupational. And we need to be familiar with both of those. So we're going to start off with occupational post-exposure prophylaxis. It's pretty straightforward. Most of us have workplace safety measures in place. This is not where most of us have problems, but some of us still do. And you'll meet Ann Zaya from the student infirmary at UF that handles needle stick exposures in Shands and UF for UF employees. So if you have any questions about occupational PEP, she's our expert. KR is a 53-year-old surgeon who receives a stick to his hand from a large hollow bore needle used in central line placement from a patient with known HIV infection. He's encouraged by the operating room staff to seek post-exposure prophylaxis. A lot of people don't ever report their needle sticks because it's a hassle, right? So you're taking calls for the needle stick hotline. What do you tell him should happen? Should he get post-exposure prophylaxis? Yeah. And we remember this is an old study. This is by Cardo in 1997. It was published in the New England Journal of Medicine. Deep injury, big risk. Visible blood on the device, risk. Procedure involving a needle that was placed directly in a vein or artery, there's a big risk. Terminal illness in the source patient, well, we don't see that so much anymore, but that might have been the case for this patient. And then with post-exposure use of zidovudine, which is AZT, the risk is much less. So we know antiretrovirals in the setting of a needle stick exposure to somebody with HIV does prevent infection. The fluids and tissues of concern, blood, visibly bloody body fluids, semen, vaginal secretions, breast milk. You're not really going to have exposure to these in the workplace for most people unless you're in a lab, but it can, these are things that we worry about. Other potentially infectious fluids include cerebrospinal fluid, synovial fluid or joint fluid, pleural fluid from the lung, peritoneal fluid from the belly, pericardial fluid from around the heart, and amniotic fluid. Low or no risk, feces unless they're grossly bloody, nasal secretions, saliva, sputum, sweat, tears, urine and vomitus. You know, unless they contain blood, they're considered low or no risk. So evaluation of the exposure, if any of you picked up the PEP and PrEP pocket cards, there's some out at the AATC table. You will have these flow sheets if you want to have them handy. So the first step is, did an exposure actually happen? I've actually had people come to me completely, like their hair standing on end, tears pouring down from getting stuck with a needle that's never ever been used. So, okay, this is a life-changing moment. So you got to know whether it really happened. So is the source material blood, body fluid, other potentially infected material, or an instrument contaminated with those substances? If it's no, they don't need occupational post-exposure prophylaxis. They may be counseling, because maybe they need to go into some, like psychiatry or something where you're not sticking people, but they don't need prophylaxis. If it's yes, then you have to say, okay, what type of exposure occurred? Was it mucous membrane? Yes, you can get blood splash in your eyes, in your mouth, across mucous membranes, and you can get HIV that way, for sure. Was it non-intact skin exposure? Did they have eczema and cracks in the skin? Or was it a percutaneous exposure with a needle stick or Sharp's injury? If that happened, then occupational post-exposure prophylaxis is recommended, depending on the source HIV status. If it's just a drop of blood or something on intact skin, there's no break in the skin, there's no cracks in the cuticles where the blood touched the person, no occupational post-exposure prophylaxis is needed. So you're thinking, okay, got stuck, it's definitely a real exposure, do I really have to worry about this? So then you have to look, okay, was the source patient even HIV infected? And we're only talking about HIV today because it's too much to talk about hepatitis B and C. But those have risks as well. You need to be familiar with it, but we're talking about HIV today. So what is the HIV status of the exposure source? If that person is tested and they're HIV negative, that you don't need occupational post-exposure prophylaxis. If the person's positive, yes, you need occupational post-exposure prophylaxis. If the status is unknown, then you try and determine the HIV status, but while you're working that up, you start post-exposure prophylaxis. If you never can figure it out, you just finish out those 28 days. If the source is unknown, so somebody, I don't know, working in a lab with pooled blood or something like that, and you don't really know for sure, then occupational post-exposure prophylaxis is generally not warranted. These are the drugs that are currently recommended. This is what we give at UF for post-exposure prophylaxis. The CDC or IDSA recommended guidelines say you can give tenofovir, emtricitabine, or Truvada with raltegravir or Icentris. The New York, New Jersey guidelines say, well, if you can use raltegravir, dolutegravir should work. It's an integrase inhibitor. It's one tablet, too. This has to be one tablet in the morning, one tablet in the evening. This one is one tablet a day plus one tablet a day. Some people find that super easy. Some people find it really hard to do something twice a day. So that is the currently preferred OPEP regimens. Non-occupational post-exposure prophylaxis is a little bit different, a little more sometimes complicated to figure out. Non-occupational post-exposure prophylaxis happens when there are risk exposures following sexual and needle-sharing activities, needle sticks outside of occupational settings, trauma, including human bites. So you have to evaluate that exposure risk again. You have to see whether something really happened that you need to worry about. Higher risk exposures are considered when the source is known to have HIV infection or has an unknown HIV status. If there's been any kind of receptive or insertive vaginal or anal intercourse, needle sharing, or injuries with exposure to blood or other potentially infectious material. Those are higher risk exposures. Lower risk are oral vaginal contact, oral anal contact, receptive or insertive penile oral contact with or without ejaculation. Now, factors that increase the risk, if the source is known, HIV with a high viral load, non-intact oral mucosa, so if you're having oral sex with someone and you have sores in your mouth, that's a higher risk. Blood exposure, genital ulcer disease, or other sexually transmitted infection, that's why we really worry about that. That's why in the afternoon we're going to have an STD talk about the new CDC guidelines, because we have to worry about STDs as well, not just HIV-related problems. So here's the nPEP for HIV algorithm. This is also on that pocket card. Higher risk exposures, so those are the folks that have high-risk sexual encounters or broken mucosa or something like that. If it's less than 36 hours post-exposure, then non-occupational post-exposure is recommended. If it's greater than 36 hours, case-by-case evaluation, consider expert consultation, and there are lots of experts but I'll give you a phone number to call for the National Post-Exposure Prophylaxis Consultation Center. Lower risk exposures, evaluate for factors that increase risk. So if it's a low risk exposure, but there's an increased risk because the person they're exposed to is definitely HIV infected, or there's other issues, then you're going to do a case-by-case evaluation, consider expert consultation. If there's no risk exposure, no prophylaxis is recommended. And hey, does this look familiar? It's the same as the OPEP one, so we don't have to think too hard. So you got your tenofovir, intracitidine, or Truvada. You can combine it with raltegravir or Icentris, or dolutegravir Tivicay. So, now on to PrEP. PrEP is pre-exposure prophylaxis. This is what we talk about in folks that do not have HIV but are at high risk of acquiring HIV. They're going to take antiretroviral therapy. It's not a complete regimen that you would use for treatment. It's only a partial regimen to prevent them from getting HIV, and it's part of a comprehensive prevention management plan. PrEP by itself, you give somebody a pill and let them go, and you haven't talked about condoms. You haven't talked about safer needle sharing practices, those kinds of things. That's really not doing the full PrEP algorithm or the recommended PrEP protocol. We really need to include prevention in there too, because the studies that were done with a full comprehensive prevention management, counseling, provision of condoms, all kinds of prevention messages. So KR is a 22-year-old man who has sex with other men. He reports inconsistent condom use. He would like to take PrEP to decrease his risk of HIV infection. He wonders, though, how effective PrEP really is, and if he really has to take it every day for best effect, or if he can just take it around the time of high-risk exposures. Well, these are the PrEP trials to date, and none of them have been perfect in every patient that was on the study, in part because everybody wonders if they really have to take it every day, and a lot of people in these trials, despite getting extensive counseling, didn't take it every day. But if you look at some of the studies in these patients, if you look at the IPREC study, that's one of the ones that's quoted a lot. The efficacy overall was 42%, but the drug was only detected in about 50%. And if you looked at people that had drug detection, 92% of people that actually had drug detected were protected. So you have to take it for it to be effective. And today, right now, we don't know whether there's any way to be protected just taking it around high-risk exposures. Those studies need to be completed, and a determination needs to be made. If you look at all these studies, the adherence was too low to assess efficacy in a couple of these studies. That's a big issue. Adherence to PrEP is critical. If you dose it 2 times a week, if the patient just takes it twice a week, it's 76% effective. If you dose it 4 times a week, it's 90%. That's pretty darn good. If you dose it daily, it's 99% effective. So really the message is today, based on the studies that we have, if we're following evidence-based medicine, we tell our patients every dose, every day. There's 4 basic steps to PrEP: a risk assessment, determination of eligibility, follow-up, and discontinuation if they're not having active, high-risk exposures. So the risk assessment is you evaluate the patient to see if they really have a high risk for HIV infection. Are they men that have sex with men? Are they heterosexual but engaging in sex with multiple partners? Or having inconsistent condom use? Are they IV drug users? So those folks are considered at high risk. You're going to assess them. There are very clear recommendations from the CDC, and also the Truvada REMS protocol through Gilead is very clear as well if you want to look on their website. It's really very clear. To be eligible for PrEP, you have to be HIV negative. You can't be HIV positive and just take, tenofovir, intracitidine, or Truvada because what's going to happen is you're going to develop resistance. It's not going to be in any way helpful. You need to be on a full HIV treatment regimen if you're HIV positive. So you have to determine that people are truly HIV negative, and you have to determine that just before they start PrEP. Because if they're, just at high risk and you might miss diagnosing HIV, if you test them 2 months ago, they're continuing to have high-risk behaviors, you say, okay, here's your Truvada, and they became positive, 2 or 3 weeks ago. So you have to know about that. They need to have adequate renal function. The estimated glomerular filtration rate has to be over 60. And you need to test for whether they have hepatitis B virus infection, because this medication regimen is effective in the treatment of hepatitis B. And if your patient has unrecognized hepatitis B and you start them on Truvada and then they stop having high-risk exposures and you didn't know they had hepatitis B and you stop the Truvada, then they can have flares of their hepatitis B, potentially fulminant liver failure. It's a big deal. So also remember, if you do that hepatitis B virus testing and they're not immune, you should vaccinate them, right? Because how does hepatitis B get transmitted? Same way HIV does. So that's a good opportunity to do some prevention for hepatitis B as well. Follow-up, you prescribe this for daily use. You tell your patient, you need to take this every day. You do periodic HIV testing every 90 days. We're not supposed to dispense more than 3 months at a time. We need to have a negative test just before we give that refill. Need to do STD testing for sure if somebody has symptoms, but also if people don't have symptoms, there's very clear times recommended in the guidelines for all of this. You want to continue doing a renal function evaluation because we know tenofovir can affect the kidneys. It's pretty uncommon to happen in people that have normal renal function and are otherwise healthy, but it can happen. And you also want to, every time you see the patient, remind them about safer sex practices, condom use, dental dams, whatever is appropriate for their particular risk issues. Discontinuing PrEP is expected. Not everybody needs it every day. It's not like taking HIV medications. Yes, once you start it and you take it forever. It's expected that at some point people will modify their risks and may not be at high risk all the time. So discontinuing PrEP is expected. When people are not in their high-risk activities, then it can be discontinued. And you may have to restart it one day. But, people don't have to stay on it forever. It's not treating an active infection. So who's at high risk? Those that have partners known to be HIV positive, those who are engaging in sexual activity within a high prevalence area, and I think we consider all of Florida, inconsistent or no condom use, diagnosis of sexually transmitted infections. If they've had STIs in the last 6 months, they're considered high risk. Exchanging sex for commodities is a risk. Use of illicit drugs, alcohol dependence, incarceration, those are all considered risks. And partners with unknown HIV positive status in any of the above are considered risks, high risk. Now, I just wanted to remind everybody about what folks with acute HIV infection might talk to you about, because we use that 4th generation antigen antibody combo assay, and it's pretty good, but it still isn't perfect. It still might miss diagnosing people that are acutely infected. So we need to know what symptoms and signs might say, okay, not only am I going to get an HIV antibody test for you, I'm going to get an HIV viral load because I'm afraid that you might be acutely infected, and you don't start PrEP until you get those results back. If somebody comes in and they complain about these while they're on PrEP, you stop PrEP and you assess them for whether they might be acutely infected. You don't keep treating through these kind of symptoms without knowing. So symptoms of acute HIV infection include fever is a main one. Weight loss can also happen. You can have central nervous system issues, malaise, headache, neuropathy. You can have lymphadenopathy. You can have a rash. GI symptoms such as nausea and vomiting. Some people get liver and spleen enlargement. It's not super common. People can have muscle aches and pains. They can have sores in their esophagus, mouth sores, pharyngitis, or sore throat. So these are things that you should think about when you're seeing patients. If they have had high-risk exposures recently and they come in with these kind of symptoms, then you need to think about acute HIV infection, not just when you're thinking about PrEP, but for all your patients. And remember, you need to add a viral load to that antibody test if you're really thinking about acute HIV infection. So Last thing I really want to talk about in regards to prevention again is PrEP is not to be used just the pill all by itself. It needs to be part of a comprehensive prevention strategy. Screen and treat all sexually transmitted diseases. HIV prevention counseling before and after each test. You're going to see them every 3 months, and they're going to roll their eyes and say, my God, when will you stop telling me this? Do you think I'm stupid? But you have to remind them every time, condoms, condoms, condoms. Give them condoms. I still give out the female condoms for my men that have sex with men because they don't break as frequently. They are not as constrictive. Some people like it better, and a lot of my guys, that's all they'll use anymore. So remember, the female condoms aren't just for ladies. They just have to take that inner ring out. Individual and couples risk reduction counseling. I really love it when folks come in with their partners and we can have a conversation, both of them together in the same rooms. They both hear the same message, and they can ask questions. It's a great opportunity to dialogue. Condoms with training and counseling. A lot of patients, they don't even know that there's an expiration date stamped on the condom package. They have no idea. And these latex condoms do break down over time. So we need to remind people, hey, here's the expiration date. Make sure it's not expired. If it is, come back. We'll give you more. And then discontinuing PrEP. You're going to stop it immediately if somebody has a positive HIV result. If they have acute HIV signs or symptoms. If they're not taking it, it's not going to work. So don't give it. If they have renal disease or a change in life situation with a reduced risk for HIV. And I have a lot of resources on this slide. This is the phone, or I thought I put the phone number on there. This is the website for the Clinician Consultation Center at the University of California at San Francisco. Honestly, I do a lot of this stuff, but I still call them and ask them questions just to make sure, you know, I'm doing the right thing for my patients. Don't hesitate. They're super accessible, very knowledgeable and friendly, and they give you good support. So they're definitely there. You're also welcome to contact me anytime. Don't hesitate, and if I don't know, I'll call them. So these are also some other resources that you might be interested in. So I wanted to give you the opportunity to ask some questions. Please hold PEP and PrEP questions, though, until we have the panel discussion. But if you have any questions about the other part of the talk, feel free to come up to the microphone. I was really clear today, wasn't I? Nobody has any questions. Thanks so much. Go out and enjoy some time with the vendors, and then come back, 11. All right, you get some extra time.